Good morning, guys. I am going to pre-record some lectures. We're going to try something out a little bit different. I want to focus on spending some time with you guys because this is kind of in-depth, doing some interactive learning in the class. There's lots of math that kind of goes along with some of these chapters. So I want to be able to spend time doing that, answering questions, doing some interactive learning with you guys next week. So I'm going to record some of the explanation pathophysiology of the chapters that we're going to cover. And then we can spend some more time in class doing some of that interactive learning. So what I would like for you guys to do, of course, is watch these videos and then take notes, bring questions to class, and then we'll do some, like I said, interactive learning. We're going to do math problems, we're going to do some case studies, and we're really going to try to pull those concepts out and apply them to help you better understand some of these concepts. So I'm going to share my screen with you guys. Okay. All right, we're going to talk about burns. Let me get my other screen pulled up here. Okay. So what is a burn? A burn is anything that is damage to the skin from an energy source or underlying structures, skin or underlying structures. This can be caused by heat, chemicals, electric, sunlight, radiation, scalds from hot liquids. So we're going to kind of talk about some of the different types of burns, but this is what we're covering in this chapter. So let's talk about the different types of burns. You can see some really cool burn pictures here. We have an electrical burn here, and with electrical burns, you're going to have what's called an entry point. Hold on just a second. I think I might move my camera. Home office. Okay. So we have this electrical burn here with, you guys can see an entry wound and an exit wound. So just depending on where they get struck by the electricity, you'll see those. These are some different, some scary looking pictures, right? So heat. That's our most common kind of burn. Fire obviously being the most common source, but can also come from a steam or a hot liquid that can injure the skin. Again, electrical burns. The severity is going to depend on the voltage that the patient was exposed to, and then of course where the electrical current traveled through. So when we're thinking about the mechanism of injury, we're thinking about where that voltage traveled through. So think of an electrical burn like an iceberg. So yeah, you're going to see a little bit of superficial injury on the outside where you have your entry and exit wound, but the majority of the damage is going to occur in the underlying structures where that voltage traveled through. And you're going to see a lot of damage to nerves, vessels, underlying structures with these electrical burns is what we're really concerned about. So think about that kind of like an iceberg. It's a good way to think of it. And then we have chemical burns. So these are caused by corrosive or caustic chemical substances that have a strong acid or base, or known as alkali. These can occur from strong cleaning products like bleach, some chemicals in the workplace like refrigerants, battery fluids for mechanics, just different things like that that people are exposed to that can, again, it's corrosive. If it's corrosive to metal, it's going to be corrosive to your skin. So people can suffer injuries that way. Okay. So there's several factors that determine the severity of a burn. So the size, how big is it? So a little teeny tiny, or is it a big, huge burn that covers a lot of area? The depth of the burn, I just realized I spelled that wrong. The depth of the burn, so how deep down it goes, and I'll show you guys that in just a second. The age of the burn victim, so who are our susceptible people? That is our very young and our very old population, right? The mechanism of injury, again, was an electrical, where did that electrical current travel, so that can determine the severity. Does the patient have underlying health problems? Most likely our elderly people are going to have those underlying health problems. So again, the age, and then other injuries sustained at the time of burn. So did they have a crush injury or a blunt force trauma to the chest? Different things like that can obviously determine the severity of the patient's condition. So let's talk a little bit about our burn depth here. I've got some pictures here for you guys that are visual learners, because I'm a visual learner too. I like to see things like this. So remember, in our anatomy and physiology, we have our epidermis, and then under that our dermis, and then hypodermis. So our first degree burn is going to cover just the epidermis. So this top superficial layer of the skin. And you guys can see a picture of it over here. It's usually kind of pink, kind of red. It's not going to blister. You're still going to have full breast cap refill. This is more like a sunburn. You laid out in the sun a little too long. And this is me every summer. I burn very easily. So this is going to heal really quickly within, 3 to 5 days probably. And it's not going to blister. These are very superficial. It does not go down into the dermis. Then you have your second degree burn that's going to extend down into the dermis. And this can vary just depending on how far it goes into the dermis. So we can have kind of a more superficial dermal burn, which would be maybe your upper portion of your dermis. And then we can have a deep dermal burn. So that could be further down into the deeper part of the dermis, maybe right above that hypodermis, right in there. This is going to be your second degree burn area right here. And again, the severity can vary depending on how far down it goes. These type of burns are going to be very painful still for the patient, because we have lots of nerve endings right here, right in our hypodermis. So they're going to be feeling all of that. It doesn't feel good. They're going to have that sluggish or absent cap refill in the deeper burns. And just depending on how deep it is, it may need surgical intervention. And then we have our third degree or full thickness burn. So when we say full thickness, that means it goes all the way down into the hypodermis, into that area of adipose or subcutaneous tissue. And this is going to be the destruction of the entire dermis. And we're going to have no cap refill on this. And this obviously is going to require surgical intervention. And then when we talk about a fourth degree burn, that is all of these layers have been burned in addition to underlying structures. So our underlying structures are going to be our muscles, ligaments, bones. So it goes all through those layers and then down into muscles, bones, ligaments. So that would be a fourth degree burn. And obviously those are going to require surgical intervention. Your full thickness and your fourth degree burns are going to require surgical intervention. Skin grafts, which we'll talk about later on in this lecture. So another thing that helps determine the severity of the burn was how much of the total body surface area is injured. So there's a couple different formulas out there. It lists a couple in your book. The most common one is the rule of nines that we use to calculate. So in an adult here, you can see that the head is 9%, the anterior and posterior thorax are both 18%, our arms are 9%, and our legs are 18%, and groin perineum is 1%. So when we're looking at a patient, we would look and see how much surface area total is burned. And typically our patients that are 30% or more of their total body surface area is burned, they're in the major burn category. These are the people that are going to need intense intervention and going to be in a burn center. And then you can see this little kiddo down here. So it's going to be a little bit different for children because their bodies are shaped differently than ours, right? They have bigger heads, they have shorter torsos, shorter legs, shorter arms. So their percentage is going to be calculated a little bit differently on a pediatric patient. So total body surface area. And then we have to also consider the location of where the burn is and what can be injured in those locations. So obviously some of our most dangerous burn locations are going to be the face, head, neck, and torso. And this is due to inhalation injury. So when we inhale that smoke, we kind of have a trigger of inflammatory responses. So it damages the cilia, which are, those little hair-like structures that help you mobilize secretions. It triggers that inflammatory response, so that's going to cause hypersecretion of mucus, and then we also have mucosal edema. So we have our hairs, our little cilia are damaged, we have more mucus, we have edema, and possibly even bronchospasm. So we're at severe risk for compromised airway blockage. So in these patients, you need to be thinking intubation pretty quickly. So what are some of the assessments or clues that your patient may have inhalation injury? So some of the things you're going to look for, the cardinal signs, are singed nose hairs, maybe black. You'll see that black soot on the face. You can see burn injuries to the lips or the oral mucosa, even sometimes on the inside of the mouth, you can see those burn injuries. They can cough up sputum that has the black carbon specks in it. Maybe when you're talking to them, if they're conscious and alert and talking to you, you can hear a hoarseness in their voice, or maybe they can't get a whole lot out, sounds really raspy. Or when you're listening to them, you can hear that stridor sound. So those are all cardinal signs that this patient has suffered an inhalation injury. So again, as a nurse in the emergent phase, we're thinking intubation, securing that airway breathing circulation, right? And then the second thing that is worrisome is carbon monoxide and hydrogen cyanide poisoning. So, and these are going to be more at risk in an enclosed structure versus if maybe the fire is outside at like a bonfire. So if you're in a house fire or a structure fire versus an outside fire, you're going to be at higher risk because those gases are contained within that structure in a higher concentration. So more likely that you're going to inhale more of it. And with the carbon monoxide and hydrogen cyanide, the carbon monoxide is going to bind to the hemoglobin and it's going to kick out and displace that oxygen. So normally, we have our oxygen that's bind to our hemoglobin and our red blood cells. Well, the carbon monoxide is like, hey, that looks like a perfect spot for me. I'm going to slide right on in there and I'm going to kick this oxygen to the side. So that carbon monoxide is taking over the place where the oxygen would normally be. And so subsequently we have hypoxemia in these patients. So our treatment for this is going to be administration of 100% oxygen. And then again, intubation to keep our airway patent with these patients. So that's another thing that can determine the severity of illness. So let's talk a little bit about the pathophysiology and some kind of the changes that happen in the immediate injury of the burn. So we know burn is a very traumatic injury that has a lot of effect on a lot of different physiological processes in the body. When burns occur, our vessels are damaged, and what's inside that intravascular space can now leak out more easily, right? So that's what we mean when we talk about capillary permeability. Those are some big words that we throw around, but basically that means that because of that thermal or that injury to our vessels, we now cannot no longer hold in what was in our intravascular space, and it's going to readily leak out, kind of like a sieve. This includes albumin. And remember, albumin is what regulates our osmotic pressure. So water is going to move out with that albumin out of this intervascular space, out of the intervascular space and into the interstitial space. So we're going to see a lot of edema, and then we're going to also see hypovolemia in our patients. They can go into hypovolemic shock. So we're also going to see hyponatremia because, as you guys learned last week, sodium goes with water, right? So hyponatremia in these patients, hypovolemia, and then subsequently what's left in our intervascular space is now thick and viscous due to the loss of plasma. And also, when our cells are damaged, they burst open and they can leak out potassium into the intravascular space. So we were going to see hypernatremia in our patients with burns. So hyperkalemia when the potassium leaks out of the cells. So we've got a lot of physiological changes going on here. So what happens when our fluid that was in our intravascular space is now leaking out into the interstitial space? So now we have decreased overall volume, and so our heart is going to have to pump and work really hard to get that little bit of intravascular volume that we have to our vital organs. So our cardiac output is decreased. So the heart is going to really have to kick into gear and we'll try to work really hard to get that little bit of volume we have to the organs. So if these patients are not fluid resuscitated very quickly, then we can have that end organ failure and hypovolemic shock. So this is really important. We're going to talk about the Parkland formula and calculating fluid volume replacement in class. So I'm saving some of this stuff for in class, but I'm trying to cover the pathophysiology behind it so that you guys have a good understanding of that when we're doing these calculations. So what are some other body processes that we need to consider when we're thinking about the pathophysiology that goes behind the burn injury? So kidney alteration. Again, our renal function, our kidneys are part of our vital organs. So we're going to have decreased blood flow to those vital organs, including our kidneys. And this can occur with acute kidney injury and renal failure. You guys are going to be learning a lot more about renal next week because that's the next chapter we cover. But just know that when we have decreased fluid, we're not going to be having urine out, right? So you're going to initially see oliguria in the patients. Once we get fluid resuscitation going, hopefully we can increase that renal blood flow and filtration. In that emergency phase, we have destruction of our red blood cells. So that releases hemoglobin, and depending on how deep the burn injury is, if we have injury to our muscles are going to release that myoglobin. So that hemoglobin and that myoglobin can occlude the renal tubules, and this can cause acute tubular necrosis. Necrosis means death, so it's death of our renal tubules, and renal failure. So that is why another reason why fluid resuscitation is so important. The greatest indicator of our fluid status in these burn patients in the acute phase or the emergent phase is our urinary output, and this needs to be at least 30 mils per hour. So if you have a question on the test, know that at least 30 mils per hour is going to be your indicator of your fluid status. So if you don't have at least 30 mils, we know something's going wrong and we're going to need to notify a physician, right? So we want to monitor our urine output, our BUN and serum creatinine levels, and we're going to report any decreased urine output or an increase in our BUN and creatinine values to our primary physician, right? And we're going to assess our urine. If we see that hemoglobin or myoglobin, it's usually a red color or red tinged urine. So that can kind of clue you into, hey, we've got muscle damage. We're seeing this myoglobin and hemoglobin in our urine, and I know that that's going to clog up and cause tissue necrosis in the kidneys. So be paying attention to that in these patients. Again, with our respiratory, we have that inhalation injury, so we want to assess for dyspnea, stridor, changes in respiratory patterns. We want to monitor pulse oximetry and our ABG values. Signs of hypoxia, restlessness, confusion, difficulty attending to questions, or a decreased level of consciousness. So your respiratory assessment is important. The GI alterations. So is the GI tract a vital organ? not as vital as some of the others. So in that emergent phase, when we're shunting blood to the brain, the lungs, the heart, the kidneys, the GI tract is kind of going to get left behind for a little bit. So we have decreased perfusion to our GI tract, and that can cause that, along with the immobility of our patients in this emergent phase, is going to have decreased gastric motility, and this can cause a paralytic ileus. A paralytic ileus is basically when your bowel freezes up. You stop that motility, that peristalsis that keeps your bowels and your secretions moving, just kind of freezes. So everything stays stagnant there. You guys will learn later when we cover GI, what we do to treat a paralytic ileus is decompression with a nasogastric tube, which is going to suck out secretions and decompress. So they'll likely have an NG tube in these patients in this acute phase that's going to remove air and secretions. So how do we know that this is returned back to normal? We have bowel sounds when the patient starts passing gas. That's when we know our paralytic ileus has resolved. Also, in that immediate 24 to 48 hour period, we have major massive stress going on to the body. And the patients can develop what's called a Curling's ulcer or a stress ulcer. And this usually occurs in the duodenum, is the most common place. And these can bleed really quickly and really easily. So we want to watch and assess for signs and symptoms of GI bleeding, which would be a drop in a hemoglobin on lab work. And then, of course, maybe we might see coffee ground emesis, occult blood in the stool. So we want to assess for those. These patients are going to be put prophylactically on PPIs like pantoprazole or H2 receptor blockers like Pepcid. Okay. Immunologic alterations, we have lost our protective barrier, right? Our skin is what protects our insides from all the stuff that's outside. So we've lost our protective barrier in some places. And then the burn injury itself produces a systemic release of cytokines and other substances that cause our immune system not to function properly. So our leukocytes and endothelial cells are not working properly. So what are we going to do to protect our patients? These are high risk for infection. So we want to do protective isolation. That means when we're going in to care for these patients, we're wearing a hair covering, gloves, mask and gown, shoes. Everything is sterile, a sterile sheet, a sterile blanket. We're going to do sterile wound care, sterile dressing changes. Everything has to be kept clean. We have to try to protect these patients the very, very best we can. We're also going to find out and assess when their last tetanus shot was. If they have not had it recently, then they're going to need an update on that tetanus vaccine to protect them. And then another mechanism of injury is our thermoregulation and our hypermetabolic state. So if I have a burn and I've lost my skin, which helps me regulate my temperature, and my adipose tissue, which again helps me regulate my temperature, I'm kind of a sitting duck, right? So the room needs to be kept anywhere from 85 to 100 degrees to help regulate the patient's temperature. And then the patient's also going to go through what's called a hypermetabolic state. I'm not going to go into this too in depth, but what you need to know is that post-burn, we have that stress response that's going to induce hormone release and inflammation. And this is going to lead to catabolism of lipids and proteins and severe muscle wasting even. So this is going to increase our patients' resting, metabolic needs, and energy expenditure. So what does this mean for nursing? What you guys need to know about the hypermetabolic state is that our patients are going to have an increased caloric need. We're going to need to increase their fat, their carb, and their protein to be able to meet their needs. In the emergent and acute phase, this may be an enteral feeding or a parenteral feeding with TPN until the patient is stabilized and our bowels are not at risk. So the primary goal of the nutrition support is to provide adequate energy supply so that our body can heal and their caloric needs are met and they can maintain organ function and survival. So I want you guys to look over and read Burn Management Table 62.3 in your book. that's an important one that I want you guys to look over and be familiar with before you come to class. So let's talk about the different phases of burn here. So we have emergent and resuscitative, we have acute, and we have the rehabilitative phase. So our emergency is that onset of burn injury to the restoration of capillary permeability, which is our first 24 to 48 hours. The focus here is stabilizing and fluid resuscitation. The acute phase is when we have that return of capillary permeability, and this is when your patient's going to start to have diuresis. So this typically occurs within 48 to 72 hours after your initial injury and will last until the wound heals. And then that rehabilitative phase is from when the burn is healed to when the patient is able to function at their highest level again. So looking closer at that emergency or that resuscitative phase, this begins at the time of injury and can last up to 48 hours. That's typically when we start to see that capillary permeability start to stabilize. So once our intravascular volume is no longer leaking out everywhere, then we move into the acute phase. So obviously our goal in this phase is to prevent our hypovolemic shock. So we're going to do that fluid resuscitation and also airway management. Another thing to consider was the mechanism of injury. If your patient had an electrical burn or if they have a cardiac history, then we're going to need continuous cardiac monitoring. Another thing to be really careful of in this emergency phase is if your patient has had a circumferential burn. So I've had a burn that goes all the way around my arm, a full thickness burn, let's say. I have that hard eschar tissue and the swelling, and the combination of those two can cut off circulation to the tissue distal to that burn. So it's really important to do your circulation checks, check your pulses, mark them with a marker, check them with a Doppler if you need to, but that's really, really important because we want to prevent loss of limb and tissue below that burn. So if it's circumferential around the arm or the leg, we need to check pulses. Circumferential burns around the torso can be worrisome because those can actually impede our respiratory status as well. Another important thing in this phase is to get that eschar off the patient. So the surgical intervention to remove that eschar or that burn tissue, that is the greatest indicator or outcome that is going to improve the patient's overall morbidity, mortality in these patients with burns. We've got to get that eschar and that burn off. So they're going to need that surgical intervention. Again, we're going to do that fluid resuscitation. We're going to spend some time in class talking about that. So we're going to be doing the Parkulin formula and calculating that out and working some of those problems together. But we're going to need 2 large bore IVs, and we're going to need to do strict INO. So again, what is our greatest indicator of our hemodynamic status? If we're having 30 mils per hour out on these patients. So if we're not, we need to notify the physician immediately if we have decreased urine output or a change in our hemodynamic status. And then when we move into that acute phase, this begins when our capillary permeability is restored. So we're no longer just leaking like a sieve all everywhere. Our fluid is starting to is stabilized and staying in that intravascular space. This usually occurs 48 to 72 hours after the injury. So the goal in this phase is to continue that fluid status and electrolyte imbalance monitoring. So we have to be careful because here we are dumping fluid, and then about that 48 to 72 hour mark, we should start to see stabilization. So we don't want to swing the pendulum too far and continue to give them too much fluid because then we can have hypervolemia and fluid overload, heart failure, things like that. So we have to kind of drop that down a little bit usually and just keep a close eye on our fluid status. Wound care, infection prevention, adequate nutrition, and pain management are our goals in this acute phase. And the acute phase can last 48 to 72 hours after the injury for months afterwards until the burn heals. So this is our goals in this phase. And then our rehabilitation phase this is the final phase of burn care. It goes well beyond hospitalization. And the goal for our patient is to achieve the highest level of independence and functioning that they can post-injury. So this is going to be outpatient care and continuing therapy for these patients long after they've left the hospital. So a little bit about wound care. So the goal of wound care is to remove our non-viable tissue and wound exudate and eliminate any previously applied topical agents. So one thing that's really important when we do this, obviously, is to be sterile, to do it properly, to be trained on it. If you ever go to work in a burn center, I'm sure that they have pretty extensive training for their nurses upon hire. One important strategy when you're doing wound care is to prevent cross-contamination. So that means that if you have a wound over here, it could possibly have some bacteria in it, but that doesn't mean this wound over here does. So they used to soak patients in like a big tub, but then that would just have everything exposed. So you could have, bacteria in this wound on this arm, but not in this arm. But then after you sit and soak in that tub, then it can go everywhere. So they try to wash the wounds separately and not have them, with the same solution, same washcloth, same things that are being used to clean the wound, try to keep them separate so that bacteria doesn't get cross-contaminated between wounds. There's a picture right here of a hydrotherapy cart. So it has, they can put this patient on it, drape their arm over, wash the arm over here, drape this arm over, wash the arm over here. It's got this floor that's got drains, so the patient's immobile and they can't take a shower, then they can bring them into this hydrotherapy cart shower and do their wound cleansing there. Obviously, these are going to be plastic liners, water filters, things that we're going to use to keep contamination down. When we're doing dressing changes, the removal of the bandage and the cleansing of the wound is really important, that we do that aseptically and use our sterile technique. And then if we're applying ointment, typically those ointments are going to be applied in a thin layer. And usually these are silver ointments, or sulfamylon is another common one, applied in a thin layer and then a new bandage placed over top. Dressings can impede circulation if they're wrapped too tightly, again, with those circumferential burns. So we want to make sure we don't wrap it so tight that we're cutting off the circulation. And we need to do those peripheral pulse checks frequently on the extremities to make sure that they are not wrapped and dressed too tightly on these people. Let's talk about debridement. So we have some different ways we can debride. Natural debridement is when the tissue separates spontaneously. This is an example of mechanical debridement. So this is eschar tissue here that they're removing, getting down to that healthy wound bed where we have capillary blood flow. So early surgical excision and removal of that devitalized tissue, along with the early wound closure, is now recognized as one of the most important factors that is contributing to the survival of a patient with a major burn injury. So getting that off quickly and soon. So these are the mechanical tools that can be used. Obviously, this patient looks like they're in the OR. Now, there can be some subsequent mechanical bedside debridement that's done in small increments that can be done by a physician or a physical therapist as part of the dressing changes. Wet to dry is not recommended with burns because when you pull off that dressing, you could pull off some of the new healthy tissue along with the eschar tissue. So wet to dry is not recommended for burn patients. And then they have chemical, topical, enzymatic agents that are available to debride wounds as well. So that would be putting an enzyme to break up and eat off that eschar tissue. Wound grafts. So we want to have it covered, right? Because we don't want bacteria and all kinds of things just lurking in the dark getting into our wound. So these full thickness burns are usually covered with an autograft. So an autograft is from the patient's own skin. So it has a less likely chance of not being rejected by their immune system because it's their own skin, right? It's not seeing it as a foreign entity. Once these grafts are put on, if blood, serum, air, fat, necrotic tissue, anything like that becomes present between the recipient site and the graft, there can be a partial or total loss of that. Infection, mishandling of a graft, shear injury when we're pulling a patient up or turning them, or even degrees of mobility can cause our graft to fail. So post-operative protection is key for caring for these skin grafts. The occlusive dressings are commonly used initially after grafting to, and also immobilization of the extremity if possible. And then of course we just need to be really careful when we position and turn the patient so that we're not compromising the integrity of that graft. I don't want to be the one that messes it up, right? Okay. So let's talk about some other nursing interventions. Pain management. Opioids is going to be your choice to manage the pain in these patients. We want to avoid IM or sub-Q injections because absorption through the tissue is unreliable during this recovery phase. We've lost, fluid and electrolyte balances and adipose tissue and just different things like that. So it's not as reliable as someone who doesn't have a burn injury. So IV is the preferred route. And we want to pre-medicate prior to painful procedures as well, such as dressing changes or physical therapy. So pain management is a big part of the care for these patients. All right, that is it. Let's see how I stop sharing the screen here. So I would like for you guys again to just kind of review your chapters, take some key notes from this, and then when we meet next week, we're going to do some interactive case studies. We're going to work out some math problems. We're going to calculate some total body surface area and some Parkland formulas. So this is kind of a baseline, and this keeps me from having to use up some time in class using the lecture. So I will post a separate lecture on our other dermatology issues from chapter 61, and I will see you guys next week. Thanks.